Hello, everybody, and welcome to Macro Pro and Friends. Today, I'm joined by Mandy Farquhar. Mandy, how are you, and Happy New Year?
Yes. Hi, Diane. How are you? How's Washington over there? Nice and cold?
Yeah, but no snow, so I like that. I like that a lot, no snow. So it is New Year's, and I'm so excited that this is our first webinar of the year. We have such great attendance, and people are flying on now. I see that number clicking over. So we're going to be talking about Medicare Set-Asides, and MacroPro has a new product that goes along with this topic perfectly. So Mandy, why don't you tell everybody about the MacroPro Medicare services we provide?
Yes. Well, when I was in the Medicare field, I would do the Social Security verifications, and it would take me quite a while. So I came on to MacroPro, and I look at their list of, items that they do, and I saw Medicare verifications. I was like, oh my God, they do those. So I decided to take it upon myself to do them for other Medicare compliance companies. So if you need a Medicare verification, you want to see if the patient is receiving benefits, if they are delayed or denied, you get that SA 3288, and MacroPro can do those for you now, and we do them pretty quick. So I hope we can help you out with those.
Right, it's not just for the Medicare Set-Asides, it's for any examiner that wants to get that done, right? Because
Yes.
we are doing servicing for other companies because, time is of the essence and they need to get things done. But you can come directly to us and provide that to your Medicare Set-Aside company and have that. So it's $175 to do it for you, unless you need a rush, a super rush, and then we would do that for you at $300, because sometimes we know it has to be pushed through quickly. All right, well, thank you for sharing that. So Mandy, I'm going to do a little bit of housekeeping, and then once we get the housekeeping done, you'll go ahead and introduce our guests. So let's get started. Today's webinar is worth 1 CEU credit. You'll be receiving that within an hour after the webinar. Now I say that, but some of your firewalls will prevent that. So it sometimes can take up to 3 days. So if you don't see it after 3 days, please let me know. If you have a problem downloading it, please go to your IT department first, because like I said, it's usually a firewall or something along those lines, and they can help you with that. You do have to be logged on to the GoToWebinar format or platform. So if you're just calling in, you will not be receiving a certificate. You have to be logged on. And again, your certificate should show up within about an hour. We have handouts for today's program and also on the flyer for the MacroPro service that we talked about. So you may want to download those now off of the control panel. And then lastly, if you have any questions, you certainly can ask those of our expert. However, he's not going to take questions, I think, immediately. He'll keep his eye looking at questions, but any questions he doesn't answer, he will get the emails and we will provide the questions so that he can reach out to you. If you want to see something again, you can always catch it on the MacroPro YouTube channel. All right, well, that was a mouthful, and I hope that you guys all have a great, wonderful new year, and that this year is just really spectacular for you. We appreciate you guys joining us, and we are delighted to be able to continually bring to you great content for your education.
So today I would like to introduce Shawn Deane as our legal expert in the Medicare compliance arena, with a role as General Counsel and Vice President of Claims Solutions at J29. With an extensive background in the legal and Medicare fields, Shawn has proven himself as a dynamic leader and invaluable asset to the organizations he serves. In addition to his role at J29, Shawn actively contributes to social causes, serving on boards of organizations like Kind Souls and Kids Chance. His commitment to making a positive impact extends beyond the corporate realm, reflecting a genuine dedication to the well-being of others. So that's Shawn. Having had the privilege of working with Shawn approximately 4 years ago, I can attest to his exceptional qualities as a professional and a person beyond his legal expertise. Shawn was not just a colleague, he was a trusted traveling companion, making our shared experience memorable and enjoyable. Shawn, take it over.
Oh, thanks so much, Mandy and Diane, and thanks so much to Macro Pro and all the attendees here today. Mandy is one of my favorite people in the industry and in the world. She's just such a great friend of mine, and we're lucky to have her if you're friends with her, and lucky to have her in the industry as well. My name's Shawn Deane. I'm General Counsel and Vice President of Claim Solutions at J29. And J29 was founded in 2017 and is a healthcare management consulting company. And we have some incredible clinical expertise, and I was lucky to cross paths with leadership at J29. And we decided in November to launch a full suite of Medicare secondary payer services, including Medicare Set-Asides and Conditional Payments and lien resolution services, and soon to be Section 111. And we're really looking to provide sort of that boutique white glove type service with customized tailored solutions. So my contact information is here, happy to talk to you about that. But we're here because we have a lot to cover today in the realm of Medicare secondary payer. And I'm going to talk to you a little bit about the format and coverage of this type of webinar. And we have to do the mandatory crowd pleasers of the Medicare overview and Medicare secondary payer refresher. And then I'll hit the three main buckets: conditional payments, Medicare set-asides, and Section 111 in that particular order. And I'm going to do something a little bit different. I'm presenting these in sort of, as we kind of warm up with this stuff, as you would when you kind of go for a workout or go for a long run. You start easy. So hitting conditional payments first with some fundamentals, then building up to Medicare set-asides, where I'm going to talk about some areas that typically don't get discussed and some things that I think get glossed over, and then get into the meat of it with the big thing that happened around civil money penalties in Section 111. And I'm going to sort of mix some things in here, talk about some foundational stuff, go through 2023 highlights that we saw, some things and practitioner points to look out for in 2024. And I also put some embedded links and resources as a reference, because I hope you get as much bang for your buck. You're spending a morning or an afternoon here with me, and I want to make sure you can use these materials later as a reference as well. So we're going to kick it off with the mandatory crowd pleaser, the Medicare overview. And from top left to right, everyone knows the Social Security amendments occurred back in 1965 with LBJ, created Medicare and Medicaid. We got Part A hospital. You don't need to pay a premium for that. You got Part B medical, that's outpatient stuff. How do you become eligible? And I know this is like high level for a lot of people, but if we have, I'm looking up, we have a ton of attendees. If you're not in the know in Medicare, it's important that you understand the mechanics of how this stuff works. So typically it's by your birthday, 65 years of age or older. The vast majority of Medicare beneficiaries are entitled due to age. You can see 88% there. But then you have a special category too below that around disability, about 12%, and that encompasses Social Security disability insurance. Those are the checks that Diane was talking about, those verification checks for SSDI. So go get to your friends at Macro Pro to figure out if an individual is receiving SSDI. And if you receive 24 consecutive months of that, you get shipped a Medicare card. Next is end-stage renal disease. And if you're going through dialysis, kidney failure, have end-stage renal disease, you become eligible for Medicare. And lastly is ALS or Lou Gehrig's. You can become eligible for Medicare that way. And in our arena, because we're dealing oftentimes with injured workers, we're dealing with a Medicare beneficiary who's under the age of 65, and it's most likely because of SSDI enrollment. Now, not to confuse the Medicare alphabet soup any further, but we have Part C, and that's totally separate than Part A and Part B. It's referred to as a Medicare Advantage, used to be called Medicare HMO back when it started in 97. About 30 million people, or just shy of over 51%. So the bulk of people now, it's tipped the scale towards most enrollees are on a Medicare Advantage plan. And they do this because you can receive additional services that you wouldn't under traditional Medicare Part A, Part B, such as hearing and vision and dental services. There are about 8,000 in our country different plans. So there's a lot of different plans there. We're going to talk a little bit about the PAID Act, how that allows RREs, or responsible reporting entities, to get at this type of data. Then we have Part D, prescription drug services. This is the newest kid on the block with respect to Medicare. That was back in 2003. 50 million people, vast majority of folks, have a Part D plan either embedded with their Part C plan or associated with traditional Medicare. Both Part C and Part D are administered by private companies. And it's of note when we talk about conditional payment recovery in the first section here, they have their own unique right of recovery separate from the traditional Medicare secondary payer channels through administrative recovery. Some takeaways here. I want to make sure folks don't mistake Medicare for Medicaid, okay? It's really important. Out where Diane, out west, you know, each state has something different. Mandy has Medi-Cal where they're at. Back where my home base is in Massachusetts, we have Mass Health, so it's primarily administered by the states, but don't get those confused. I also have some resources here. Data.cms.gov and the Kaiser Family Foundation, fantastic websites if you're looking for data and statistics. It's where I pulled these around Medicare. Okay, Medicare secondary payer. We got to do this slide and we're going to do it real quick and painless. So fast forward from 1965 with the Social Security amendments that created Medicare all the way up till 1980. What happened? Well, people started living longer because of the advancements in medical science, and more people were having injuries, and the federal government started looking at instances where there was going to be some strain on the Medicare trust, and they saw one way to preserve the Medicare trust is by requiring Medicare to pay secondary to any type of insurance that was out there that had responsibility to pay. Those folks are known as primary payers. So when I say primary payer, think workers' compensation or liability or no-fault insurance or any type of self-insured. And the purpose of enacting Medicare secondary payer was to defer a cost shift over to the Medicare trust and mandate that those insurance carriers and self-insureds paid for injuries that they were responsible for, or if there was a reasonable expectation that a payment could be made too. Now, it's important to note here that all throughout our time here this afternoon or this morning, if you're on the West Coast, I'm going to be talking about non-group health plans. So NGHP, work comp, liability, no fault. But Medicare secondary payer is applicable to employer-sponsored group health plans, but we're not going to be talking about that. It's just important to know and keep in the back of your mind. All this MSP stuff, Medicare secondary payer, is encompassed in a federal statute, which the citation's there, corresponding rules or regulations that I've noted, but also an entire emerging body of case law, agency policy memos, reference guides, user guides, internet-only manuals, MLN articles, Medicare intermediate manuals. All of this stuff composes Medicare secondary payer. So don't just think, oh, it's just the statute and the regs. There's a bunch of other stuff that encompasses this. And at the end of the day, the goal is to prevent a cost shift over, and it's to prevent Medicare from making payment when another entity known as a primary payer could be making payment or has responsibility. And it's in place to prevent an eroding Medicare trust, which is expected to be depleted by the end of 2031. Remember when I talked about some resources? I have links down at the bottom if you want to take a look at the statute or the regs or the reference guide or the conditional payment or Section 111 resources. They're there as well that you can use as a reference. So rolling right into conditional payment recovery, we're going to go not necessarily easiest to hardest with respect to compliance points, but we're going to take a less detailed to most detailed look at some changes that happened in 23 and what's coming in 24. So this will be really a refresher, but I'll have some practical practice tips as well too. MSP statute, as I indicated on the previous slide, is effectively a prohibition against Medicare making a payment when there is an insurance carrier out there who has responsibility to pay. And I put the chapter and verse there. So it's really a coordination of benefits mandate. However, there's a really important caveat within the statute that allows for a conditional payment. And I'll explain to you what that is. So Medicare says Medicare can make a payment on the condition that it's reimbursed if the primary payer is not going to make a payment within a reasonable amount of time. That stuff's all defined by regulations 411.21. We don't need to get into that. but just realize it has a practical effect there. So a conditional payment is a payment made by Medicare during the pendency of the claim, for which a primary payer should have made payment but didn't happen to make a payment. Why does this happen? It happens because of the practicality of timing. So an individual is injured on the job, maybe in an automobile accident, any type of bodily injury claim. It's not like the insurance carrier is going to be there within minutes following that person to the emergency room to pay for treatment that's rendered. So timeliness is really key there. Conditional payments exist so Medicare can provide timely treatment to its beneficiaries. It's also to assist providers too. Providers don't want to be hanging around for a long time until the claim settles or till there's primary payer responsibility established to receive payment. Now, what's the risk and exposure here to conditional payments? And I'll really be focusing on risk and exposure for each of these conditional payments, MSAs, and Section 111, because I think it's always important to have that in the back of your mind, because it really guides your risk management philosophy and the approaches you take to each one of these compliance components. So with respect to Medicare conditional payments, you need to know Medicare can seek recovery of these things against a whole host of parties to the claim, against the original payer who paid out on the claim, maybe a settlement, or who assumed ongoing responsibility for medicals. We'll talk a little bit about what that means. Go after directly the claimant or the plaintiff beneficiary, can even go after their attorney, can go after providers, can go after state agencies. You can look at 411.24 and see all the folks that they can go after. And so brass tacks, where does it exist? Well, first, if you don't pay Medicare back after they've issued a demand for repayment, interest can accrue. And at that point, it becomes a federal debt. What else can happen? This doesn't happen a lot, but there is some case law out there that indicates, that provides some information, if you want to read it, around when Medicare can file a civil suit for double damages, so twice the amount of conditional payments. This can be done through a private cause of action or done also through the Department of Justice. And again, Medicare is not in the business of suing people to recover conditional payments, but it can happen, and it's an option available to them for recovery. And then you have Treasury, and this is an agency mechanism of recovery that's really unique, and it involves a delinquent debt that is mandated to be referred over to the U.S. Department of Treasury, and it can take a couple of different routes. It can go to a private collection agent, which is a private commercial company that Treasury is mandated to have on panel, and they're basically like debt collectors. It can also go to Treasury proper to recover, effectively just sending a letter, and then it can go to the Treasury offset program, where if an entity has a delinquent debt, conditional payment debt that's outstanding, and any monies owed by the federal government. So this can really, for anybody in the municipal realm who gets frequent grant monies or the like, they can offset that payment. And then there's also the state reciprocal program, where if states participate and they're owed debt, that the federal government and state government can coordinate recovery in that regard too. So there's real risk and exposure here, uniquely different from something like, let's say, Medicare Set-Asides. Okay, so what are some important practitioners' pointers here? I think the biggest is for folks, because this is an area where I think it's most confusing, especially for workers' compensation individuals out there, is to understand that there are two unique recovery models, and it's a bifurcated process. And I put a definitions section over to the right of this slide because I realize for the uninitiated, I'm throwing out a lot of acronyms. And at least for folks at home, you can kind of follow along, but I'll do my best to define all these acronyms that I'm spitting out here. But the first is the Benefits Coordination and Recovery Center, the BCRC. And if you can think BCRC goes with TPOC, you'll be in good shape, because the Benefits Coordination and Recovery Center, and you might be thinking, well, aren't those the folks that do Section 111? Yes, they are, but they also seek recovery against a Medicare beneficiary following a TPOC or a settlement, versus a bifurcated system of recovery with the Commercial Repayment Center, the CRC, who goes after primary payers when there's ongoing responsibility for medicals established. So think BCRC, TPOC, settlement, goes against a beneficiary. CRC goes after like a work comp insurance carrier following ongoing responsibility for medicals, and that can happen on an ongoing basis until the claim is completely resolved. So there's two different modes of recovery. With each mode, Section 111 reporting is critical, and you're going to see Section 111 reporting come up over and over, even in our Medicare Set-Aside talk here in a few minutes, or the Medicare Set-Aside section. It is the primary area that CMS, the Centers for Medicare and Medicaid Services, utilizes to drive data to enforce various areas of Medicare secondary payer compliance. So reporting is very critical because with both with the TPOC reporting and ORM reporting, it's going to drive each of those contractors' recovery efforts around conditional payments. Another big pointer here for folks is in work comp, prior to a settlement, just because you get a no claims paid letter doesn't mean conditional payments are done. There could be a subsequent settlement or post-settlement rather, and the BCRC can come back and deliver a demand letter to the injured individual post-settlement. And then lastly is appeals. Some really quick hit appeals tips here. The first is to adhere to all the deadlines. The easiest way to lose on appeal is to blow a deadline and have Medicare dig their heels in the sand because procedurally you're out on a technicality. Second is to ensure every argument that you have at your disposal is presented at the first level go forward. If you, not always, but in many instances, if you leave out and maybe you're waiting going, gosh, maybe I'll get it at the ALJ level if I don't get it at the quick. You need to present all arguments at that base level go forward. Also follow open correspondence. Anytime you're engaging with the CRC or the BCRC on a demand, ensure that if you've lodged an appeal that they have open correspondence flags so it doesn't erroneously go over to U.S. Department of Treasury and now you're dealing with a Treasury issue just based upon a technical error. And then because it issued this past year in 2023, follow the NGHP Appeals Reference Guide. I think it's a fantastic resource. For anybody who was at the MSPN annual event, this was discussed quite a bit. And really understand all the basis for appeals that are delineated in there so you know what's at your disposal when you're reviewing a statement of reimbursement or payment summary form and you're going through that appeals process. What else in 2023 and 2024? So I talked about the appeals reference guide. Keep an eye out for updated portal functionality and user guides. One was recently issued just a few weeks ago. I think as we do every year, we're going to see an increased enforcement with U.S. Department of Treasury. Keep an eye out for these folks at Life Wallet, known also as MSP Recovery LLC. They're out there in the Medicare Advantage realm seeking recovery pursuant to a private cause of action theory. And then in general, I think we're going to see an uptick in Medicare Advantage and Part D recovery, just because as I showed you on the very first slide, we've seen such an increase in enrollment with respect to Part C and Part D plans. And those folks are going to be looking to, if you follow the news and saw some of the things with Humana, you're going to be seeing probably areas to contain costs, and one of those is to either prevent prepayment or to seek recovery for any overpayments that were made. All right, moving right along. We're doing good on time. We have a big chunk of Section 111 stuff to talk about, which I know everybody is incredibly excited for, but we're moving right along into Medicare Set-Asides. Quick refresher here. If you look at the MSP regs and the statute, you won't see the words Medicare Set-Aside indicated anywhere in those, but you will find a particular reg found at 42 Code of Federal Regs 41146 under the subheading of workers' compensation that's really interesting and which forms the basis, at least the fundamentals of where Medicare Set-Asides come from. And effectively that regulation says that Medicare is prohibited from making a payment after the settlement when there's been a workers' compensation settlement that provides for future medical compensation to the individual. So in another way of saying that is you got an accepted workers' comp claim, you're out in California, you got a CNR, and you compensate the applicant for future medicals. Medicare is precluded from making payment post-settlement. They, the applicant, can't go out and buy the proverbial boat, okay? So I'm gonna fast forward through a lot of policy that happened, but essentially, as we know, an MSA allocates an anticipated post-settlement lifetime healthcare prescription drug, items and services, all the expenses that Medicare is otherwise covered by Medicare for the entire life of that individual. And the purpose of the MSA is to prevent a cost shift over to the Medicare program after the settlement. So they can't go out and buy the boat. They have to use that chunk of money for Medicare covered items and services that are related to the industrial accident. And like I said, you're not going to find the words MSA in 42 USC 1395 Y little b2 or the regs, but and therefore there's no statutory mandate for an MSA, and there's no statutory or regulatory mandate to submit these things. But the only mechanism whereby primary payers and stakeholders in the industry know to, quote, protect Medicare's interest or take Medicare's interest into account is through an MSA. And so what's the primary risk? Again, we're coming back to risk and exposure of not incorporating an MSA. Well, if you look at the reference guide, there's a litany of stuff it talks about, and you can even look in 41146, talks about if there's a cost shift, Medicare won't recognize the settlement. WCMSA reference guide talks about subrogation and rights of recovery, but what we really know is the primary risk is Medicare not stepping in and paying for treatment post-settlement if their interests weren't considered by way of an MSA. So you're looking at the top of the screen, go, why is Section 111 and reporting an MSAs here? Well, something occurred in mid-November of 2023. CMS held a webinar. Maybe some of you were on it, maybe some of you weren't. I'm gonna break it down for you. And I think it's really important, and I feel like it got glossed over a little bit, in part, and understandably so, because of the final rule around civil money penalties in Section 111. So it kind of flew under the radar a little bit, but let's bring it back so we can take a look at it and see what this really means. There's going to be testing in 2024, Section 111 reporting testing associated with work comp MSAs and TPOC reporting, and it's anticipated by January 2025, so a year from now, the submission of certain MSA data elements in the Section 111 TPOC are going to be required. Okay, and this involves settlements that included a Medicare set-aside. Submission, importantly, of this information has to be done regardless of whether it was voluntarily submitted through the WCMSA submission process with the WCRC, or if it was a non-submit instance, okay? That's really important. Doesn't matter if the MSA was submitted to CMS, reviewed and approved or not, or if it was just done and it wasn't submitted to CMS. CMS is still going to be looking at Section 111 reporting around MSA data if there's a settlement and an MSA was incorporated. Okay. Work comp MSA Section 111 information needs to be submitted, again, for all work comp TPOCs. What is the data? I truncated this a little bit. There's a few more data elements, but I wanted you to get the gist of it. They want to know what the MSA amount is. They want to know what the coverage length is, meaning what is the life expectancy, adjusted or otherwise, of the individual. So how long is this MSA going to cover for? They want to know if it was lump sum or annuity. They want to know the deposit amount, how much went in it, if it's a lump sum, or what's the seed amount, if it was annuitized. They also want to know who the professional administrator's employer identification number is, if that's applicable, if it was professionally administered. Hopefully it was. Also, it's very important to note this has nothing to do with liability claims. Work comp settlements only that incorporated an MSA. Also, it doesn't alter any other Section 111 reporting obligations. This has nothing to do with Section 111 civil money penalties. This has nothing to do with CMS submission voluntary review thresholds. This Section 111 mandate does not require submission to the WCRC for review and approval or anything like that. It doesn't change CMS submission policies, just changes the requirement for what data needs to be submitted when there's a work comp settlement that incorporated an MSA. Here's the timeline. Soon, we're probably going to be hearing from CMS about an updated file, an error code layout. There will be some testing that is available for folks to do in Section 111 in the fall of this year. And then a year from now, year from this month, we're looking at likely implementation of this. So it's coming up. This is definitely something to look out towards. But I think most interestingly is what they're going to do with the data. And some of this, admittedly, on my part is speculative, but I think, I'm going to do my best to articulate the reasons why I think this is something that folks should probably be paying attention to. So why Section 111 is a mechanism? Well, CMS as an agency can't at this point in time mandate submission. It's a voluntary process, but it will allow CMS with unprecedented oversight and visibility and the potential to enforce some policies they currently have in place with respect to, number one, went back to risk. The risk here is Medicare might not pay for the beneficiary's future treatment post-settlement. It'll allow Medicare to effectuate coordination of benefits post-settlement, and it's really the vehicle, the only vehicle they have to use that's already in place to provide for this data. Congress, as they do most times when they pass legislation like this, gives an agency wide latitude with respect to requirements. And in this particular case of Section 111, they certainly gave the Secretary a wide berth as far as what they can require. At the bottom, you can take a look at this. The agency seems very receptive to industry input. Advise there be additional details forthcoming. I assume there's going to be more notices, probably other webinars. There's an email here that you can reach people at CMS to ask questions about this and the like. And what's the backdrop here? And this is by no means official, CMS guidelines. This is just my interpretation here. I see this. See the backdrop here is what happened in 2022 with respect to CMS's articulation of a non-submit policy. And I took some snippets of quotes from Section 4.3 that most of you are likely familiar with, but if you're not, in early 2022, CMS issued their policy guidance around how they view non-submits. They rolled back some of the more harsher language and changed it from such things as like shall to may, and I'll get into it right now. So effectively it says, this is CMS's words, unless a proposed amount is submitted, reviewed, and approved, CMS cannot be certain that the Medicare program's interests are adequately protected. Okay. CMS then goes on to say that it may, at its sole discretion, deny payment for medical services related to the work comp injury, requiring attestation, so submission of information to Medicare to prove appropriate exhaustion equal to the total settlement before CMS comes in and pays for injuries. Okay, that makes sense. That's already established. We already knew that. Procedures for rebuttal. Unless it's shown at the time of exhaustion of the funds that both the initial funding of the MSA was sufficient, okay, that goes to sufficiency of the allocation itself, and utilization of the MSA funds were appropriate, that goes to administration. This will result in the claimant needing to demonstrate complete exhaustion of the net settlement amount rather than the CMS approved amount. Okay, that's very interesting. So it appears CMS has articulated a position around non-submits, but indicated some sort of procedures whereby an aggrieved individual who's had a claim denied can go through. Now, because CMS submission is not mandated, there's no formal appeals process here. There is an appeals process for a beneficiary if they have a claim denied. We don't know how a lot of this is going to play out. However, the last bullet here, I think their Section 111 policy kind of goes in line with how CMS may attempt to enforce something like the above. So Fry asks us, Shawn, how does CMS conduct post-settlement oversight at MSAs? I'm really glad that he asked. This is something that doesn't really get talked about a whole lot. I've only seen a couple mentions of it, but I think it's important that we go through a little bit about the mechanics, because I think this area will be something we're going to see in 2024 and beyond. We're going to see CMS get more sophisticated around the oversight they have and the coordination of benefits around MSAs. It's going to make professional administration that much more crucial, regardless if you have a voluntarily submitted or a non-submit MSA. And I say this because CMS said in the webinar that the MSA information they were looking to get in the Section 111 TPOC report would be used to coordinate post-settlement, used to flag the beneficiary's common working file to prevent payment post-settlement. So how's it done today? You submit an MSA from left to right, submit an MSA and it's approved and finalized. When the amount's approved, CMS checks if the person's not yet entitled to Medicare, and once they are, the claimant is enrolled in Medicare, and the BCRC is the contractor that's responsible for monitoring the case go forward. The administrator or the self-administering beneficiary sends in an annual attestation on an annual basis within 30 days of the settlement date. They send in documentation summarizing that the account was used permissibly. It shows account balance and all the expenditures and so on. So the BCRC, i.e. Medicare, understands that the funds were used appropriately. And what happens at that point? Contractor ensures that no payments related to the underlying injury occur until the MSA is used up. This is accomplished by putting a W code for workers' compensation MSA in the beneficiary's common working file. A common working file is a master electronic record that every Medicare beneficiary has, and it's used to coordinate benefits. This capability has been around, if you look to the right, since 2009. I cite the MLN Matters article that it occurred in. So this has been around forever. Medicare's had this stuff ready to go in a forward-thinking way, knowing that they had an opportunity to use this, and now through Section 111, they're going to, it sounds like they're going to be using this in a more concerted effort and more programmatically. Okay. So what happens here? How does the oversight work? So when someone goes in and treats, and I'm talking fee for service now, so Part A and Part B, there's a Medicare administrative contractor, or a MAC, that sits between the provider and Medicare that reviews these claims, and they look to see if the common working file is flagged. So if the common working file is flagged with a W code, Medicare should effectively deny payment. And what happens is, once it can be shown that the funds have been properly expended and either depleted completely or temporarily exhausted, Medicare removes, the Medicare administrative contractor removes that code. Actually, it's the BCRC that removes that code. But if there are funds available to pay, the code stays the same. So it's a little bit complicated. I went through this very quickly, but you have the slides here. Take a look at this stuff. It's really important to understand how this works. It's all kind of hidden within the WCMSA reference guide and several other areas. It's even referenced in, these are the Medicare secondary payer manuals, the IOMs or internet only manuals. There were some updates to how providers need to look at this stuff. It's fascinating. I think as either stakeholders within the workers' compensation industry or service providers, we kind of tend to think of like, okay, we're looking towards settlement, we're looking towards care of the beneficiary, we're looking towards resolution of claims and claims handling, but we don't really realize all the mechanisms and infrastructure that's in place post-settlement to where the rubber meets the road, because you could have the most perfect MSA down to the penny, but the second the beneficiary post-settlement goes and buys the boat, it's sort of all for naught. So there's a lot to this stuff post-settlement, and I really think this is going to be something to watch in 2024. Amended review very quickly. For voluntary CMS submission, CMS did away with a 6-year time limit. There's still 12-month waiting period. I'm not going to go through all this. I think most folks know what happened here. What should we look for? And I know I'm going lightning round now. I think we should take a look at see if CMS is going to issue a zero allocation policy in the WCMSA reference guide or come out with some sort of memo around that. Again, I think there's going to be a big focus on post-settlement oversight by CMS of MSAs. This is something that really hasn't happened as much as it likely could. And I think Section 111 is the mechanism to make it happen, which will highlight the importance of professional administration. I wonder if we'll see any tweaks to Section 4.3. We'll have to really take a look at if the timeline sticks for January 2025 for TPOC reporting. There's some interesting things in the fiscal 2023 data that I think you could take a look at. You saw an increase in decisions, saw an increase in counter hires are up. You saw medical spends up, but RX is down. And lastly, we always have to have this here. We're going to see if LMSAs make a comeback. We saw that the agency pulled the reg that they had, but it's always on the horizon. But I'm not certainly not holding my breath. Okay, with 20 minutes to go, we're going to dive into probably the biggest thing that happened this year, and probably for primary payers, responsible reporting entities, the most important thing to keep an eye on. And everything kind of has been coming back to Section 111, even with, as you saw, integration with recovery, and now we see Medicare Set-Asides. Section 111 is really the hub that drives a lot of this stuff. So by way of background, this goes back to 2007 when the MSP statute was amended to add this electronic reporting requirement. And as if we needed another nomenclature for parties, primary payers in the parlance of Section 111 are referred to as responsible reporting entities, or RREs, and they have to report certain claims involving bodily injuries with Medicare beneficiaries. Why do we have Section 111? It allows Medicare to coordinate benefits. It allows Medicare to go, oh, I need to deny payment because there's a primary payer that should be paying, or whoops, we made a payment, we need to recover against an entity or an individual who has received a primary payment or has responsibility under the MSP to pay us back for those conditional payments. It's the only of note MSP compliance point where there's an actual penalty associated with failure to comply. You have interest that can accrue in potential lawsuits and Medicare conditional payments. You have risk of denial of service and Medicare Set-Asides, but this one actually has a penalty associated with this. And it should be noted that civil money penalties were always part of the original statutory provisions. The agency just wasn't directed exactly how to do that. More on that in a minute. So what are the mechanics? Very quickly, we have the query process. How on earth do we find out if an individual is a Medicare beneficiary? Well, we collect their first name, last name, date of birth, social, and gender, and we ship it off to Medicare through the Section 111 query process, and we determine if they're entitled to Medicare, yes or no. We can also get some Part C and D information thanks to the PAID Act. And then the two main reporting requirements are ORM and TPOC. ORM is ongoing responsibility for medicals. This is the primary payer going, hey, Medicare, heads up, we're responsible to pay. You shouldn't pay. You may want to flag the beneficiary's common working file and coordinate payment so you're not making payment and ensure that we're paying. It also alerts Medicare in the ORM instance of the fact that if Medicare did pay for conditional payments, like the CRC, they can come back and recover against the primary payer. And then the TPOC is letting Medicare know total payment obligation to claimant that there is a settlement. So this alerts Medicare to the fact that there was a settlement. For most of the folks on this call from California, if there was a CNR, you'd report a TPOC event along with ORM termination and be done with the claim. Okay, civil money penalties. We're getting to the heart of the matter. We're digging in. Like I said, in 2007, there was civil money penalties attached to it up to $1,000 per day per claim. But there was an amendment to the Medicare Secondary Payer Statute back in 2012 called the Strengthening Medicare and Repaying Taxpayers Act, the SMART Act for short. That had a bunch of amendments to the MSP statute. There was a statute of limitations. There was the portal was required. There was an expedited way to get conditional payments, all sorts of interesting things in there. But most notably, there was a requirement that the agency go through the rulemaking process with respect to how and when CMS could issue a potential civil money penalty, or CMP for short, with respect to Section 111 non-compliance. There was an initial advance notice of public rulemaking that came out in 2013. There was very little activity between 2013 and 2020 when we first saw a proposed rule, and then there was public comment. And following that public comment period, CMS tweaked the rule a little bit. CMS issued this final rule on CMPs on October 11th of 2023. Okay, what are the highlights here? The big one, there's no changes to Section 111 reporting. The CMP rule, final rule, doesn't affect anything with respect to current reporting obligations. Also, noteworthy, the prior proposed instances of noncompliance aren't applicable. There was a bunch of stuff in that initial proposed rule. There was stuff around accuracy, stuff, there was compliance thresholds, there was instances where if recovery information contradicted, none of that's in there. As we get to it, it's all about timeliness. Important to note too, this CMP final rule is prospective. There will not be any retroactive enforcement related to noncompliance. Okay, digging into it. Time here matters, okay? It's all about timeliness. A civil money penalty can be imposed in instances where the TPOC or the ORM record wasn't successfully reported in a timely manner. And I'll talk to you about what that means. And the determination is going to be made by comparing the date the record's accepted by CMS via Section 111 against when CMS should have received the reported claim. So how is that determination made? You have to look at the TPOC and the ORM as separate. If the TPOC's reported and accepted within a year, so 365 days of the settlement date or the date of the funding delayed beyond TPOC start date, and that just occurred, whichever's later, the date of funding delayed beyond TPOC start date just are instances when a different date goes in because the settlement gets funded later. In any event, that's what they look at for TPOC. In ORM, if it's timely, if it's reported and accepted within a year of the effective date where ORM was assumed. This gets a little bit more nuanced, and I put the chapter and verse in the Section 111 user guide so you can check out exactly what that means for effective date for ORM, okay? Also, civil money penalties are only going to be contemplated for an untimely add record. So we're talking about new records reported. We're not talking about updates or delete records to existing Section 111 records. Okay, step right up here. So there's a tiered approach. This is only applicable to NGHPs, not talking about group health plans. So workers' compensation, liability, no fault self-insurance. There's a tiered approach. So anything greater than 1 year late but less than 2 years is $250 per day per record. Anything greater than 2 years but less than 3 years is $500, and anything greater than 3 years is $1,000 per day per record. So it's a step up as far as levying a civil money penalty. It's not just straight up $1,000 regardless. There's also a cap. Total penalty for one instance of noncompliance will not exceed $365,000. And you have to adjust that for inflation in 2024. So it's $521,220. And if you can't do math like me, look at the chart below, and I put the ratios of rate inflation for 2024 against the 1,500 and 250. Okay, there's also a statute of limitations. It's 5 years, and the clock begins to tick when the record is reported, or very importantly, when CMS obtains information that could reasonably lead to the discovery of non-compliance. CMS used this as an example in their most recent webinar, such as a corresponding self-report, when you call up the BCRC to self-report a claim, okay? All of this doesn't mean you can just wait the clock out. It doesn't mean you can fail to report and somehow be immune to a potential civil money penalty. Safe harbors, some circumstances here. So CMS indicates that responsible reporting entities permitted to offer mitigating evidence showing, hey, here's why civil money penalties shouldn't be levied. Here's some reasonable basis for why the record wasn't reported timely. And CMS indicated that all reasonable evidence will be considered. And then there's safe harbors with respect to the query process. So this is when I mentioned first name, last name, date of birth, social, gender. If an RRE can't get that information and they can't determine whether or not they're dealing with the beneficiary, then they can't report. So it could be a late report. So there's safe harbors. You try to get this at least once in writing, once by mail, once over the phone. And CMS notes if an individual unambiguously indicates their refusal to provide this information, claimant beneficiary is saying, nope, not going to give it, then no efforts needed. I would definitely document the heck out of that one. Okay, and what happens if you are potentially in violation? there's going to be a correspondence process, informal and formal CMP notices. The informal CMP notice is just a letter emailed to the RRE's authorized rep. The account manager will be CC'd. It's going to contain information regarding the alleged non-compliant record. You got 30 days to respond from receipt of that to respond with mitigating factors. And then there's the formal CMP notice process when it's sent certified mail, indicates, hey, a CMP is coming, and it will provide, or at that point, the RE would be able to go through the applicable appeals process to appeal that, which I couldn't imagine they wouldn't. How is CMS going to find out about records that could be potentially associated with the CMP? They're going to look at 1,000 records per year, and you got to really dig into that to determine what that is. So they're going to go 250 records per quarter, a random 250 records per quarter, not per RRE, but for every record during that quarter. And it's going to be a pro rata share between group health plan, which there's way more of those than NGHP, and NGHP records. And that pro rata share could shift between quarter to quarter, CMS indicated. I think they said 60-40, 70-30 sometimes. So it's not going to just be 250 NGHP records. It's going to be a mix of both. And remember here, I have to drive this home. It's timeliness of an accepted report. That's what's going to be reviewed. What's the process going to be? They indicated, the agency indicated, while contractors might help in gathering information, it's going to be CMS proper making all decisions on CMPs. So it's going to be Centers for Medicare and Medicaid Services doing it, not any of their contractors. TPOC and ORM, two totally separate records, two separate reporting obligations. It's probably statistically unlikely, but there's a remote possibility that one RE could have the same TPOC and ORM record. It's also very unlikely, but an RE could have more than one record selected for review in a single review period as well. But I mean, based upon the figures and the volume of records going over, it's very, very unlikely. So what are some important dates? October 11th, 2023 and 12/11/23 have already passed. The final rule is effective. Then we look a year out. So 10/11/24 this year, October 11th, that's the final rule applicable date. This is the date after which the 365-day clock ticks for when records need to be submitted in a timely fashion for purposes of levying a CMP. Then you go a year after that, 10/11/25. This is when the compliance review period begins. And I don't know why they picked April 1st. It's not April Fool's, but CMS will begin reviewing on April 1st, 2026 audits for the prior quarter. That's your timeline. And so what are some of my words of wisdom here? RREs must continue. They have to continue with a focus on quality and accuracy. If you have records with errors that are rejected, those could cause delays and a resulting delay in reporting. So it's not like you just have to just go, oh, we just got to get things in on time. You're not going to have an accepted record if there are rejections. Not to mention the fact that, as I indicated before, more so than ever in 2024, Section 111 drives so many of these MSP compliance processes, least of which is MSAs, but I mean, conditional payments are entirely driven by this stuff. And we're going to be looking at reporting Section 111 data for purposes of work comp TPOCs with MSAs that are involved. So it's really critical. I think the basics are crucial. Have an accurate profile report up. Make sure you go through the profile report annual recertification process. Make sure everyone's contact information is up to date. The last thing you want is for CMS not to be able to get a hold of you if you have an informal notice or a CMP notice. I think claims records, tracking them, and documentation are going to be vital, especially around mitigating factors if there's a late record. I think it's important for REs out there to have some sort of independent audit function beyond their reporting agent to ensure that they're looking at prior quarters records and ensuring timeliness of reporting in addition to accuracy. And then stay up to date with all the changes in Section 111 reporting. There are going to be instances where if CMS makes changes in policies, that could be a mitigating factor with respect to a CMP. I would take a constant look for an updated Section 111 user guide. sign up for email alerts on cms.gov. There was just an updated Section 111 user guide on 1/22/24, so just very recently. And then certainly consult with legal counsel, expert legal counsel in Medicare secondary payer if you ever receive any correspondence from CMS related to a civil money penalty. And then, ask questions and engage with your assigned EDI rep, or reach out. I mean, I commend CMS on the amount of town halls that they're doing lately, and the amount of outreach that they've done around this and the FAQs that they've put out. But there's an email there, Section 111 cmp@cms.hhs.gov. And with that, I'm 4 minutes under time, Mandy. And I'd just like to thank all of the attendees here, and certainly big thanks out to Diane and Mandy at Macro Pro. They have such a great webinar series with so many different subject matter experts in the workers' compensation industry, and it's been a privilege to have you join me this afternoon. And I hope you all enjoyed the content yourselves, and I wish you a great year coming up, and hopefully I'll be back to see you on a Macro Pro and Friends webinar soon.
Excellent. Well,
Yes, Shawn.
there was one question. Did you see the one question in the chat box? Maybe you could take a second and answer that.
Yes.
Let me take a look at it.
Read it to you, Shawn?
Yeah, why don't you?
Okay.
Yeah, just read it out loud.
So-
Let's see if I can do it. If
so
not,
it
I'll get back
says-
to the person.
So we secured MSAs and the applicants want a full buyout. We don't know what they actually do with the money. Does CMS actually come after these people? If we enter an ORM term date, we are no longer on the hook technically for treatment after that, ?
Yeah, so, I mean, this is why I feel that professional administration is so important. I mean, you hear all the time applicants indicating, frankly, like, I'm going to take the money and go on a vacation, or I'm going to buy that boat or buy a new truck or go to Vegas and, put it all in red. In that instance, it's very unlikely that the primary payer has any direct exposure in relationship to those statements that the applicant made. It would be preferential to make sure that the responsibilities of the parties post-settlement are clearly outlined in the CNR for sure. The short answer is, if that beneficiary goes out and misspends, misappropriates, or mismanages those Medicare set-aside funds, it's very likely they're going to lose their Medicare benefits until they can demonstrate via the attestation process that I outlined that they've properly spent the money. Depending on whether it was a submit or non-submit, Medicare may pay additional scrutiny to the sufficiency of the MSA, but most likely that beneficiary will bear the brunt of any potential exposure with respect to the MSA. It's a great question.
You have one more? Can we do one more?
Sure, 159.
Will there be a penalty for failing to report MSA data in a Section 111?
There won't be a direct penalty for failing to report. That's a good question. Reporting has to do with timeliness here. So if they're, and this wouldn't be till 2025 when CMS rolls that out, let's say they have to report MSA data in the TPOC, and they fail to report and they receive, or they misreport and they receive an error, and that causes a delay, it's possible, but there wouldn't be a direct CMP related to for failure to report the MSA data.
Thank you, Shawn.
Excellent.
Welcome.
Well, we
Thank you.
appreciate you being here. For those of you that would like to hear this information again, it will be on the Macro Pro YouTube channel. And for those of you in the Orange County area, we are going to have a Macro Pro and Friends on March 19th. It will be a in-person conference. We haven't done those in Southern California in a bit. We're hoping this is the year that, we will be able to have people come and not have gigantic no-shows. And honestly, that's the reason we had to stop them, is we had so many people register, not show up, and that became quite a big burden financially for our sponsors. So we certainly hope that you will join us at one of our events, and just watch the Macro Pro website for all of our events. They will be listed whether they're in person or on webinar. Until the next time, thank you very much for joining us. Thank you, Mandy.
Thank you.
Bye-bye.
Bye.
Thank you.
Bye. Bye, Shawn.